So I'm now going to take too much time, and we'll get started with the first lecture, and that's going to be presented by Dr. York Pei from University of Toronto, and he's going to talk about diagnosis and prognosis of ADPKD.
Thank you, Vishal. Can I advance this? Okay. Can I go back to the beginning, please? Yes, okay. So my task today is to talk about risk assessment for autosomal dominant polycystic kidney disease. So now that we have the first drug, disease mechanism modifier drug called tolvaptan, approved for treatment of this disease, we have to identify patients who are most likely to benefit from this treatment because it is an expensive drug and it does have significant side effects. So this is just a kind of a summary of some of the key countries and regions in which tolvaptan had been approved. And the approval indicate that patients need to be in a high-risk category. However, there's no uniform consensus of what patient would be regarded as high risk. So it is my task today to try to go over some of the evidence about the different prognostic tools that we have available, the potential advantage and shortcomings that they have that allow us to do risk assessment. When we think about risk of progression of ADPKD, we can think about using well-defined clinical symptoms and kidney function measure, the rate of change in kidney function or the degree of kidney dysfunction as marker to identify patients who may be at risk for fast progression. We can also look at total kidney volume because there's a fair bit of work suggesting that it is a good surrogate marker for stratifying patients at different risk groups, as well as genetics, and I will touch on all three areas. So first, kidney imaging-based prognostication. From the CRIS study, we have learned that kidney function in most ADPKD patients remains stable for the first 3 to 4 decades, and then only during the more advanced stage of the disease that it starts to decline, and it can decline fairly quickly. In the meantime, the kidney volume on average grows about 5% per year in a semi-logarithmic or exponential fashion in the adult lives of these patients. So total kidney volume has now been shown to predict kidney disease progression in ADPKD. This is data taken from the CRIS study in which cohort of patients that are enriched with characteristic for progression were followed and observed with yearly MRI kidney volume and kidney function measurement. And you can see that from the beginning of the study and with advancing time, that the kidney volume increase associated with decline in the GFR. And this relationship become much more significant at the later stage. This is at 8 years, although now we have data up to 10 or 11 years. And what is interesting to note is that the correlation coefficient, when you square it, provides an estimate of the variance that is explained by this relationship, which is 42%. So it's fairly good, but not perfect. So the Mayo Clinic classification has been derived, and looking at a large cohort of patients that had total kidney volume measure and putting them against the age to provide a prognostic marker and about the risk of progression. And this work is also validated by looking at the serial decline of the GFR of these patients. And so according to this classification, you have the class 1 pattern, which is a typical PKD, showing generally diffuse disease involving both kidneys. And class 1A and 1B patients have relatively slow progression, and it's thought to be favorable prognostic group. And CDE, the much faster progressor. In the 1C group, I think because most patients would use an ellipsoid formula to estimate the total kidney volume, there's potential for misclassification to the 1D or 1B group. So in our mind, we kind of think of it as an intermediate group, whereas 1D, 1E are the severe fast progressor. If you use this classification, it is important to look at the imaging pattern, not just the kidney volume, because there is patterns that are associated with the so-called class 2 or atypical PKD cases. And this kind of pattern include unilateral polycystic kidney, asymmetric polycystic kidney, segmental or lopsided polycystic kidney. All these patterns in common is that there are some part of the kidney in a somewhat older individual who are completely disease-free or polycystic. And this pattern may correlate to a mechanism called somatic mosaicism. And they have a distinct and fairly good prognosis. And then there is another additional pattern associated with kidney atrophy involving one or both kidney. So these are the representative pattern that you can see. The atypical pattern, you can see sometimes you can really complete sparing of cystic disease involving one big part of the kidney, for example, here and here. And so all these patterns in common. So this is highly unusual for the classical polycystic kidney disease that are transmitted through the germline. But this is increasingly recognized and are suspicious of this phenomenon called somatic mosaicism. And these are examples of the atrophic kidneys. So we have the opportunity to look at a big cohort of patients that really reflect a real-world kind of setting of patients that come for risk assessment, close to 500 patients that we have MRI imaging, and then we find 7% of them had this kind of type 2 or atypical PKD pattern. So they need to be excluded. It is also important that when you use this kind of risk assessment, one of the idea is that a patient with normal GFR can have high-risk characteristic based on their total kidney volume, whereas those who have already significant kidney dysfunction or kidney failure is obvious by the eGFR measure, may not be obvious because they have normal kidney function. And this is a hypothetical modeling based on the Tempo 3, 4, and Reprise data, suggesting that if you have very late advanced stage disease, the benefit of tolvaptan treatment in delaying ESRD onset may be relatively modest. Whereas if you have good kidney function and high-risk kidney characteristic based on, for example, the TKV age measurement, that you may get significantly more benefit from delaying ESRD. There's also data to suggest, well, maybe total kidney volume is not necessary. You could just measure the average length of both kidney. And if it's greater than 16.5 centimeter, it's just as good as using total kidney volume. I seem to have some problem. Equivalent to a high adjusted total kidney volume of 650 ml, which would be something like a 1 liter unadjusted. and in predicting the probability of having a CKD 3A stage. So this is the study that suggests using the CRIS cohort. However, I think that there are potential drawbacks of just using kidney length, and I just want to highlight it for you. First of all, there's much more variability in measuring kidney length by ultrasound versus MRI. And that if you just look at kidney length without looking at the imaging pattern, you will not exclude the atypical PKD2, so class 2 imaging class, that these kind of atypical cases. And then more importantly, if you just use kidney length alone, then kidney length of 16.5 centimeter in an 18-year-old versus a 60-year-old patient have completely different meaning without adjusting to the age. Actually, you cannot look at the or assess the trajectory of the growth rate of the kidney. So I think this is a limitation of just using this, and I think this approach needs to be validated by real-life clinical data. I'd like to turn to the use of mutation-based prognostication. This is a study that was done in Toronto, and we looked at 220 families that were comprehensively screened for PKD mutation. Our cohort reflect more a regional sampling of cases rather than patients from the CKD clinic. So spectrum of mutation tend to be much milder. A quarter of these patients have PKD2, which is associated with mild disease, and another quarter with the non-truncating PKD1 mutation, which is also associated with mild disease, and about 1/3 had the truncating PKD1 mutation, which is associated with severe disease. And 15% of our patients, we could not find a mutation, and many of this will have the atypical pattern that I show you for the class C2 image, and suggesting they have a very different prognostication. From this 220 family, we were able to recruit their affected family member. So in total, we were able to look at the kidney survival, defined as absence of the need for dialysis or transplantation in 780 patients. So you can see that patients who have PKD1 truncating mutation by age 50, half of them would be on dialysis. By contrast, PKD2 patient, this is shifted. The mean age of needing dialysis is shifted to age 80, so very significant prognostication. Patients with no detected mutation also do very well. And then you have two other categories, those with non-truncating PKD1 mutation, and then a small group with in-frame insertion deletion in the intermediate. The genotype not only affect renal survival. When the PKD1 truncating mutation patients started dialysis, it also impact on their life expectancy. One of the problems of using gene-based prognostication is that we now know, and this poster presented today, that 21% of patients with a protein truncating mutation can have very mild disease. We cannot actually tell them apart from the PKD2 mutation, suggesting that they have some kind of favorable or protective modifier effect. Another additional complication of using gene-based prognostication is within family variability of the disease severity. And if you look at the age for end-stage kidney disease and plotted some of our family, this is one family with, in the vertical line with 3 affected individuals who had reached ESRD and their age on the y-axis. You can see a lot of variability. And this is thought to be related to a modifier effect due to additional genetic or environmental factors. And because of this effect, using mutation class, even though it predicts very well the group behavior for an individual patient, I think there is potential for error. So I think that it is important to recognize that, and so we don't generally recommend using the mutation class for the individual patient prognostication. From our risk assessment program, the past 2 years, we actually had studied 500 patients referred to us from more than 100 community nephrologists in Toronto area. And we did total kidney volume, collect all the clinical information and genetics on all these patients. We can use these individuals, patients, or the cohort, and then to assess kind of some idea about some of the risk assessment guidelines that had been proposed. Recognizing that these guidelines are not static, they are evolving. As we have more information, they are likely going to be refined and then changed. But in the literature, there are 2 sets of published guidelines, one from a Canadian group, one from the European Dialysis and Transplant Association. So how do we assess risk assessment? And we have to make some kind of assumption. They are not perfect, but nonetheless, it gives us a way to try to estimate how good the risk assessment guidelines are. So this exercise, we make the underlying assumption that most patients in the Mayo Clinic imaging class 1D, 1E are at high risk for progression to early ESRD. And so if you have a rich risk assessment guideline that can enrich a high proportion of these high-risk patients while excluding most of the low-risk patients, then the guideline would provide most clinical utility. So this is our patient cohort, about 500 patients, and we excluded those who had not sufficient eGFR data, as well as the atypical cases. And we had a cohort of 474 patients. This is their age, mean age 44 years. eGFR at the time of the imaging for TKV is about 80 ml per minute, and their height adjusted total kidney volume about 700 ml. So the Canadian guideline, I just want to emphasize the strongest recommendation. This is for the use of tolvaptan, and it was recommended that it should be used for patients between age 18 to 50, eGFR using the CKD-EPI formula greater than 45 ml per minute, and TKV greater than 750 ml. So how does it perform if we apply these guidelines in our real-life cohort? So we find that if you look at the Mayo Clinic imaging class, about 40% could be considered as low risk, and then another 30% each intermediate and high risk. So at the baseline, the absolute number of high risk, if you use the 1D, 1E group, is about 30%. Once you apply this guideline, you exclude a number of individuals who didn't fall within it. Then what you then get is here, you do enrich from a relative proportion of from 30 to more than 60% in the high-risk group. But at the same time, you have 10% of the low-risk group being selected for tolvaptan treatment. So these patients probably shouldn't be selected, and they would be receiving the drug inappropriately. The European guideline is using a different step algorithm, and the first step is to look at the eGFR at a certain range and over 3 different age strata, and then the second step make use of the rate of change of the slope of eGFR, and then the additional steps such as looking at kidney volume and family history in the subsequent steps. If we apply our cohort, again, the 30% had high risk 1D, 1E at the beginning. If the step 1 is just the 3 strata of age and eGFR criteria, we find that about 55% of the 1D, 1E patient would be excluded at this step. And then if you apply the slope to identify rapid progressor, another 28% of the 1D, 1E in patient get excluded. So in the end, there's an enrichment, but there's also exclusion of a lot of the patient that would be considered as high risk if you use the Mayo Clinic 1D, 1E classification. So this is here. There are additional nuances that we have to wrestle with. This is just a plot of our data showing the high adjusted TKV, eGFR. We arbitrarily cut the patients into 4 quadrants, those with an high adjusted total kidney volume of 900 ml per meter, which is equivalent to 1.5 liter. Consider those above as a high-risk category, and eGFR of 80 for normal or below normal kidney function. So you could see this group of patients who have big kidney and low eGFR are the ones who had high risk, big kidney, and progression already to CKD stage. This group tend to be younger, have big kidney, but because they're younger, their kidney function remain normal. This group here are individuals who have low kidney volume and normal eGFR, and most of them would be expected to do quite well. But then we have a group here, which is a group that is a bit intriguing because this individual would be expected to have low kidney volume and yet reduce eGFR. So what is going on? So one thing we did find is going back to see these patients, because many of these blue dots are Mayo Clinic 1A, 1B, which would be thought to be the lowest risk group. What we find is that 30% of these patients, we also have measured creatinine clearance. There's a discrepancy between the eGFR and measured creatinine clearance. 30% of them, even though the eGFR is less than 80 ml per minute, they measure creatinine clearance based on 2 or more measurement is greater than 80 ml per minute. So that there may be a discrepancy and they may be potentially misclassified depending whether you believe measured creatinine clearance is a better test than eGFR. There may be other nuances. They could have concomitant kidney disease, diabetic nephropathy, GN, renal vascular disease. I think these are generally uncommon causes. Now that some of these patients have no mutation detected, we may also have to exclude other unusual causes, genetic causes of polycystic kidney disease. So in conclusion, risk assessment in ADPKD is an evolving process that needs to be refined by new clinical data and test technology. In our center, we use a Mayo Clinic imaging class. We think that it is probably the single best risk assessment tool. Even though we do genetic testing as part of our research, we don't think this is reliable enough to provide good prognostic information at the level of individual patients because of a significant modifier effect. I think the performance of the risk assessment guidelines will undergo further evolution and refinement, and then eventually I think the best guidelines should enrich high risk while minimize low risk patients, as they will have most clinical utility. And thank you very much for your attention.